Well, thank you very much. It's certainly an honor to be here, and I'm looking at what I consider to be a outstanding session with some very interesting topics here. By way of disclosure, besides my relationships, I have to admit that the United States has no approved, FDA-approved bifurcation devices, so I'm going to put this together from what I would consider to be my perspective as an interventional cardiologist looking at diagonal disease for a while and trying to understand what role this would have in our treatment of these patients. So I want to start with a case. It's going to look a little bit like what you just saw. This is a 55-year-old male, hypertension, hypercholesterolemia, type 2 diabetes, presented with unstable angina, negative biomarkers, had a anterior distribution abnormality, and catheterization showed a dominant circumflex and bifurcation LAD, diagonal disease, with preserved LV function. And here you can see we have a Medina 111, and this is I guess the grounds at which we're finding ourselves working in the cath lab frequently and trying to decide what the best therapy is. And I'm going to leave you here with this, and we'll come back to the case and show you what we did at the end of this. So by way of introducing where we are in terms of the thought process, at least in the United States, is that based on data such as this, which is patient-leveled pooled analysis of the Nordic and British bifurcation studies, you can see under almost all circumstances that looking at any of the metrics, whether or not it's TLR, TVR, or MACE, it actually favored a simple approach, meaning provisional stenting and two-stenting technique, only if there were some issues that precluded a provisional approach. And you can see that this has been introduced as a class 1 indication in bifurcation lesions recommendation, shown here in the 2011 guideline, showing a provisional side branch stenting should be the initial approach, and a two-stent approach should be used only when there is concern about being able to get back into the diagonal vessel. Guidelines are one thing, actual practice or another, and we know that probably there is no single bifurcation lesion that behaves just the same as any other one you've treated, and it's access into the side branch itself, which seems to be the biggest challenge that we have. When we looked at two-stent techniques, what are some of the issues that we have? We get stent distortion, as shown here in some of these photo micrographs of models of stenting of the side branch. You end up with multiple layers of struts when we have drug-eluting stents. It's challenging to understand what effect that is going to have on healing. We end up with flow disturbances, uncovered struts, lots of malapposition, and in short, it's just a mess. One of the things that we look forward, though, to is that we should treat these patients just as we treat any other complex PCI patient, and it would be nice to have a strategy as well as the technology that would allow us to do this in a consistent and repetitive fashion. So you want something that you can do simply. You don't have to be extraordinarily imaginative. Obviously, the key here is to have side branch access, and that's what the stent technology should allow us to do. Ultimately, you also want to have decrease in outcomes. So you want to have a decrease in stent thrombosis rate, which we know can be increased at the side branch under some circumstances, as well as decreased restenosis. So I'm just going to take you through some photomicrographs of some of the bifurcation stents that have been termed dedicated devices, meaning that the sole purpose of this is to allow side branch access. And in my own opinion, that's probably a better term to use than a dedicated bifurcation stent, because that's more self-describing. What we can see here are three of the stents. The pedal stent was one of the earlier ones, and you can see it has a rather unique sort of conformation on the bottom, showing that, in fact, somewhat non-physiologic right angle approach, and you can imagine that would be problematic in a lot of large bifurcation and side branches which do not come off at 90 degrees. Shown here are different forms of side branch access stents. You can see on the upper right, the Frontier, which had probably undergone the greatest evolution in clinical trial work, is really designed to create a carina which allows side branch access without really intending to treat the side branch fully. And as we can see in the case that we just saw, oftentimes there may be disease simply beyond the ostium, in which case you're going to have an additional stent anyway. If you look here at some blown up photomicrographs on the far right, we can see that what we've done is through the sidewall of the stent that we have created somewhat of a bridge that goes across the carina of the main vessel into the diagonal branch. And I want you to remember this image because I think this is the key one that tells us that with today's provisional stenting techniques, this in fact may be what we're achieving with a single stent without having a dedicated stent to do that. We have other stents which have had somewhat of a unique approach here. On the upper left, we can see the DVAC stent, which was designed to sit at the carina, again, without treating either one of the two main vessels, but recognizing the importance of having to treat into the branch vessel and allowing access simultaneous to both of those. And then finally on the bottom, and I'll show just a couple more images of this, we have the Tryton stent, which is probably the most advanced in terms of clinical trial. And I'll just talk about this as we see a flow model. I don't know about you all, but I always like seeing models and things moving around, and kind of helps illustrate the point better than me standing up here and trying to describe it. But what you can see is that the device hinges on having a sleeve of a bare metal stent into the diagonal branch, and then minimal scaffolding as you come back into the main vessel. And the concept here is that we want to start with the diagonal or the branch vessel first, securing access into that vessel, and then allowing us from there to use this as a platform which, as I had said earlier, can simply be used depending on what kind of further anatomy that you have. They're going to take this out in just a second and show you in this model what a final version might look like. I think one of the things that's helped us understand bifurcation treatment is that when we see these models and we see some of the benchtop, we really have a great idea what it means, for example, not to perform a final kiss and what it looks like if we just do one simple balloon dilation. So there we have that now with the Tryton dedicated stent itself on the left, and then the stenting of the main vessel on top of it. So this is the results of the Tryton study in a randomized large comparing the Tryton approach to provisional stenting. Was presented in JACC earlier this year. We can see here target vessel failure, target vessel MI, and clinically driven TVR were not different between the provisional stenting shown in orange and the Tryton stent shown in blue. And in fact, there was a trend towards more TVF and target vessel MI. And we can see here that there was definitely a trend towards more MACE in the Tryton group. If you look at it a little bit more carefully, though, we can see that based on the branch vessel size, that most of this unexpected lack of a benefit was driven almost entirely by vessels smaller than 2.25, and when I refer to the vessel, I mean the side branch. So we can see that the trend towards MACE in the Tryton group was driven by small side branches, and I think at best we would say that there may be parity or equivalence here, but certainly was not a home run in terms of showing that we would have better outcomes if we use this approach. So given that we have limited trial data examining the benefit, probably again trying to provide access and then a carina which is accessible There are some other techniques which I wanted to describe real quickly, which may have put us in a position where the emphasis on dedicated bifurcation stents may not be as important. So the first of these is shown here. This is with newer generation drug-eluting stents, and we are looking at comparing the DK crush, so that's double kiss crush in the blue versus provisional stenting in the green, and we can see whether or not we're looking at freedom from TLR or freedom from any MACE, that in fact the DK crush was superior to the provisional, which really flew in the face of all the traditional data we had been seeing, as I had shown earlier in my presentation. So all of the metrics that you might want to look at all of a sudden seem to be better with a two-stent approach as opposed to a single stent approach. One of the other techniques I think that we've learned, and again I reminded you of that image that I think is very important in your mind, which if you look at the POT technique, the proximal optimization technique, you can see it's really designed to achieve the same thing. So in the main branch, taking a large diameter, small length balloon and post-dilating the stent across the origin of the diagonal, in fact, makes it easier for you to actually access the side branch, and at the same time creates a favorable entry into that side branch, very much like the Frontier side branch access stent. We've all been intrigued by perhaps an approach of provisional side branch stenting with some form of suppression of restenosis. Of course, we knew brachytherapy was one of the initial approaches, and since that fell out of favor, drug-eluting balloons have been on the rise. They're leading in the periphery, but perhaps not in the coronaries. So this is a clinical trial that was published last month, which is the Babylon trial, looking at the use of a drug-eluting balloon versus provisional stenting. And unfortunately, as you can see here, whether or not you look at TVR or TLR, all of the rates were higher in the drug-eluting balloon sidearm. So I think at this point in time, we'd have to say the drug-coated balloon is not ready for prime time. So let's go back to our case. We were one of the centers in the United States that were part of the Tryton clinical trial, so I actually have a case from our lab where we did use a dedicated device, and I'll just take you through the steps here. If you remember, this was Medina 111. Here we have wires in both the LAD and the diagonal. We're pre-dilating, and in both here, this was a sequential pre-dilatation approach as used by this operator. Here we have the Tryton 2.5 referring to the diameter in the side branch, a 3.5 in the proximal vessel, and you can see all the markers that are necessary so that you can align the dedicated sleeve of the stent into the diagonal, as well as the scaffolding across the diagonal into the main branch. Here the stent has been deployed, and you can see the really reasonable result in the diagonal. That was post-dilated with a 325 balloon across the diagonal, and then a 3.5 into the proximal LAD. Here we have stenting of the LAD with a 3.5 by 23 Zions V, and then post-dilated to a 3.75 by 20 balloon. And obviously with the Tryton stent now in place, we have access to the diagonal branch, which is fairly sizable, and there's going to be a final kiss here, and then we'll see the final result in momentarily. So perhaps not a perfect result, but knowing how difficult it can be to treat Medina 111 in the LAD and diagonal, I think very acceptable. I thought these were kind of interesting because part of the clinical trial we had to do intracoronary ultrasound at various steps here, and I think the one image that's perhaps compelling is the upper right, where we look at the carina, and we can see, as opposed to perhaps a provisional side branch stenting, what if you do the same image, we have a very nice large area that easily could be re-engaged if needed in the event that a future problem arises, such as restenosis. So in trying to answer the question, are dedicated bifurcation stents ready for prime time, I'd have to say first that there are newer techniques such as the DK crush and pot, which make side branch much easier than it had been in the past. And perhaps because of this, a dedicated stent may not have the same compelling importance that it once did. Second, the Tryton study results are really not compelling that dedicated side branch devices are superior to provisional stenting, and I think is really somewhat putting a hold on the rush for enthusiasm for these kind of devices. What I do think, though, is that they definitely will have a role in niche therapy in certain patients where the angle, the size are so important to the patient's well-being that having access is going to be of preeminent importance, and these devices certainly can provide that. So thank you very much.